So in these countries, we're being asked to actually stand those fundamental purposes on its head and to have a treatment plan in which, as part of the treatment plan, we have the option. And the option is, okay, I understand that you're ill and you've been ill for a while and you're suicidal, but the fact is that we can now, since if we're in Belgium and if we're in the Netherlands, and by the way, soon to be in Canada, we can say, okay, but another treatment option is I help you die. And I either will write you a prescription that you'll take yourself, like we do in the United States, in 5 states now, although in the US it's all limited just to the terminally ill, or come in on such and such a day and I will give you an injection and I will kill you. Or I'll send you to the end-of-life clinic, if this is the Netherlands, which have such clinics down the street. By the way, those clinics often take patients whose primary treating physicians either refuse to do it or don't approve of it, so you can skirt your regular physician by going to these specialized euthanasia, I guess, Soylent Green centers that are available there. I and many, many colleagues challenge the idea that there is such a thing as a terminal psychiatric illness. There are so many different modalities of treatments we can offer people, way beyond just another medication. We can offer them ECT, we can offer them transcranial magnetic stimulation, we can offer them vagal nerve stimulation, we can offer residential rehabilitation programs, vocational rehabilitation programs. A lot of people are seeking this because they're lonely. As a matter of fact, in the Netherlands, a recent case series has shown that one of the indications for people being euthanized is not because they have this disease or that disease and so forth, but they're actually accepting tired of living as a criterion that could fulfill this. You can imagine that we're already having severe limitations in the area of mental health care when it comes to funding, access, manpower, shortages. In more than in any other field, our patients and the kind of care they need is often very, very limited by the insurance plans that they have. And also, we treat people who very often, very commonly, do refuse treatments. Treatments that could be very life-saving, maybe because they seem scary, like electroconvulsive therapy, which, by the way, if I was seriously depressed, that would be the first thing I would use because it works so predictably more than any other modality. Or the nature of their illnesses, they don't really think they need it, or they're hopeless and helpless, which is one of the symptoms of their diseases. And yet, what we're providing and they're providing over there is a kind of shortcut, as opposed to let's beef up the whole access to care and all of these complex and expensive alternatives. Let's just say we can kind of shortcut all of that. You can imagine the potential for coercion, abuse, and there have been a number of cases that doctor shopping, patients making up history, because after all, we have confidentiality, so you don't necessarily can demand that a person provide you all their records, or they could fabricate things in order to be able to seek the legal suicidal option.